time, I would like to thank the planning committee for giving me this opportunity to present. I will be discussing the effect of CFTR modulators on the progression of cystic fibrosis-related diabetes. So to begin, I will mostly discuss the mechanisms that are involved in the pathogenesis of cystic fibrosis-related diabetes. Then I will briefly go over the role of CFTR in the regulation of insulin secretion from the beta cell. And then for the majority of my presentation, I will be reviewing the effect of CFTR modulators on the glucose tolerance, insulin secretion, and the progression of CFRD. So CF is caused by mutation in the CFTR gene, which results in abnormal chloride transport in epithelial cells. This is one of the most common disorder in Caucasians. And with improved survival due to the use of CFTR modulators, CF-related comorbidities have become more apparent. Cystic fibrosis-related diabetes is the most common endocrine complication of CF. So 2% of individuals with CF have CFRD in childhood, which then increases to roughly about 20% of adolescents. And by the time these patients reach adulthood, the incidence increases 40 to 50%. At this time, I would like to mention that given the use of CFTR modulators and increased survival, the current estimate of the incidence of CFRD will be bypassing the 40 to 50%. Studies have shown that hyperglycemia and insulin deficiency in CFRD leads to a decline in pulmonary function. Hence, optimal glycemic control is imperative. According to the CFRD guidelines, we should only be using the 2-hour oral glucose tolerance test to screen these patients for CFRD. The annual screening usually begins around 10 years of age. With that said, there are few exceptions to this rule. If there's a patient who is planning a pregnancy, or if a patient found out that she's already pregnant, then this 2-hour OGTT test should be performed. Furthermore, if a patient will be undergoing any solid organ transplantation, then they should also be undergoing OGTT. Currently, insulin is the only treatment of choice, as most of the studies have shown that oral diabetes agents that we use for treatment of type 2 diabetes are not as effective in improving either the nutritional or the metabolic outcomes for CF patients that have CFRD. So moving on to the mechanistic views on the pathogenesis of CFRD. CFTR mutations result in reduced as well as absent protein function. The consequences of this CFTR protein dysfunction in the lungs have been very well studied, given that that is the primary pathology. However, we have also learned over the last 1 decade that CFTR protein is expressed in the pancreas, intestines, sweat glands, as well as the kidneys, where this dysfunction leads to pathologic changes as well as fibrosis in these organs. So this figure here shows you the complex pathogenesis of CFRD. I know this is a very busy figure, but let's start out by looking into the center part of this figure. The defective CFTR leads to exocrine pancreatic insufficiency, which is a hallmark of CF. It is present in about 85% of CF adults. This then leads to pancreatic damage, given that there's decreased bicarbonate to chloride transport, which leads to the blockage of the pancreatic ducts, hence leading to autodigestion of the exocrine as well as endocrine pancreatic tissue. Given the fat-soluble vitamins as well as antioxidants malabsorption, it also predisposes these patients to increase oxidative stress. The increased oxidative stress further affects and decreases insulin secretion from the beta cells. Studies have also shown that CFTR plays a role in regulating glucagon secretion from the alpha cell. And in these patients, due to the defect CFTR, there is increased glucagon secretion, which frequently leads to hyperglycemia observed in these patients. In addition, CF liver disease is also very common in CF patients. Studies have also shown that there is increased gastric emptying as well as reduced incretin signaling, which leads to postprandial hyperglycemia. Given the recurrent infection as well as chronic inflammation, we also have decreased insulin sensitivity, and corticosteroids are very frequently used during CF pulmonary exacerbation, hence leading to further beta cell dysfunction, decreased insulin secretion, which increases the risk of these patients to develop diabetes. Previously, it was believed that CFRD was primarily a consequence of the fibrotic destruction of the pancreas. However, some of the recent studies have given us some further information that CFRD is the result of decreased first phase insulin secretion, whereas the second phase insulin secretion remains intact. I would like to point out at this point that the main difference between the first phase insulin secretion and the second phase insulin secretion is that first phase is depolarization dependent, whereas the second phase insulin secretion is depolarization independent. So recent studies have suggested the plausible role of CFTR in the regulation of insulin secretion from beta cells. Now, we also note that functional CFTR channels are required for insulin exocytosis from the beta cell. So let's take a closer look. This figure here shows a normal beta cell on the left-hand side. And here is a hypothesized CF beta cell. The main difference here is that in the normal cell, we have a functional CFTR channel, which is primarily responsible for chloride efflux out of the beta cell. Whereas in this CF beta cell, we have a dysfunctional CFTR channel, which prevents chloride efflux out of the cell, hence reducing insulin secretion from the beta cell. This figure shows us the same process, but in much more detail. I would like to point out that all the dotted lines here show the proposed mechanism, so they have yet to be confirmed. As most of you are familiar, going back to our biochemistry classes early in medical school, the glucose enters the beta cell through the GLUT2 transporter, where it is phosphorylated to glucose 6-phosphate. This leads to generation of ATP, which then promotes potassium ATP channel opening, leading to membrane depolarization. The membrane depolarization process leads to opening of voltage-gated calcium channel, permitting calcium influx into the cell. This then leads to opening of CFTR, which leads to chloride efflux, which then promotes calcium binding to the insulin granule, and this leads to insulin exocytosis. So in beta cells with CFTR dysfunction, this process is primarily hampered, which prevents calcium influx into the cell, as well as calcium binding to the insulin granule, hence leading to decreased insulin secretion from the beta cell. This figure here shows the classification of CFTR mutation. Thus far, about 1,700 mutations have been identified. For the purpose of this presentation today, I just want to mention that these mutations have been classified into 6 classes. Just to keep in mind that class 1, class 2, and class 3 mutations lead to severe disease, whereas class 4, 5, and 6 leads to much milder phenotypes. Patients that are homozygous for class 2 mutation are at increased risk of developing CFRD. So moving on to CFTR modulators. These are basically medications that enhance the expression and function of the dysfunctional CFTR protein. Ivacaftor was the first CFTR corrector that was approved back in 2012. This was single CFTR therapy, followed by lumacaftor and ivacaftor, which primarily consist of dual CFTR modulator therapy. Here, the lumacaftor is a corrector, whereas ivacaftor is a potentiator. This was approved for treatment in 2015, followed by another dual therapy known as tezacaftor-ivacaftor, also consisting of one corrector and one potentiator. This was approved in 2018, followed by the approval of first triple therapy consisting of two correctors, elexacaftor and tezacaftor, and a potentiator, ivacaftor. The first triple therapy was approved in fall of 2019 for patients that have CF pulmonary disease. So now let's take a look at some of the studies that have focused on insulin secretion and whether or not the use of these modulators improve that. This was one of the very few studies which initially focused to determine whether CFTR is involved in insulin secretion. This study used ivacaftor. This was a pilot study where they compared the baseline and then the 4-week OGTT and IVGTT after daily ivacaftor therapy. This table shows the patient characteristics at baseline, and what you are seeing here is actually a very wide age range, from 6 up to 52 years. This was a small study consisting only of 5 patients. As you can see, 2 of these patients had CFRD, whereas 2 patients had normal glucose tolerance and 1 patient had impaired glucose tolerance. This figure here on the left-hand side shows area under the insulin curve. And what we are seeing here is an improvement in insulin secretion in 3 out of 4 of these subjects. I would like to point out that the significant change that we are seeing in the insulin secretion were noted in patient number 2 and patient number 4. And these were both the pediatric patients. This figure here shows acute insulin release in response to glucose. And what we are seeing is a significant increase in insulin release, also seen in 4 out of 5 CF patients. In 2 of these patients, patient number 1 and patient number 5, the use of ivacaftor led to an increase in acute insulin release, where prior to treatment, these subjects had no measurable insulin secretion. So what this study tells us is that the use of CFTR modulators in pediatric patients led to an improvement in insulin secretion. So the main difference between pediatric CF patients and the adult CF patient is that in peds, their beta cell mass is largely intact. So in adults, as beta cell mass is lost over time, given the progression of cystic fibrosis, the role of CFTR in regulating insulin secretion actually becomes more critical. So in conclusion, this study suggested that there is a direct role of CFTR in insulin secretion, but larger long-term studies were needed to determine whether the early use of CFTR modulator therapy will either delay or prevent the development of diabetes. This is a second study which also focused on the use of CFTR modulator therapy and whether that made any changes in insulin secretion. This was actually a case series, and the main difference between this study and the previous study that I mentioned was slightly longer study duration. Here, they also used ivacaftor, and the treatment duration this time was actually 16 weeks. The top figures here shows the area under the glucose curve, which did decrease by 12%. What we are seeing here is an increased insulin secretion, which was more pronounced right around the 30-minute time point. And here the increase in insulin secretion was close to 40%. In patient number 2, we are seeing a reduction in glucose, which was about 16%. And in the case of insulin secretion, we did notice a significant increase, which was about 77%. So this case series showed the beneficial effect of 4-month ivacaftor treatment on glucose metabolism. However, still at this point, we did not have studies with longer treatment duration or consisting of larger patient population. So this was another study, and this was actually one of the very few studies which looked into the effect of dual CFTR modulator therapy, assessing the role of lumacaftor, ivacaftor on glucose metabolism and insulin secretion. The duration of treatment in this study was about 8 weeks, and they basically assessed OGTT and IVGTT at baseline and then 8 weeks after treatment with this dual CFTR modulator. This study also consisted of a very small patient population. Here you can see that the age range was 13 to 33 years. Pre-treatment OGTT showed that 2 patients had impaired glucose tolerance. 1 subject had normal glucose tolerance and 2 subjects had indeterminate glycemia. After 8-week treatment with this dual CFTR modulator therapy, 1 patient progressed to CFRD, 3 patients had indeterminate glycemia, and 1 patient had normal glucose tolerance. This figure basically shows the area under the glucose curves as well as area under the insulin curves. So you can see here that in case of patient number 4, this patient had worsening of glucose tolerance and progressed to cystic fibrosis related diabetes. In patient number 5, they actually had a reduction in glucose tolerance, an improvement in glucose tolerance, which was associated with an increase in insulin secretion. Whereas in case number 1, 2, and 3, we failed to see similar effects of dual CFTR modulator therapy. And there was no improvement in insulin secretion post-treatment. So in conclusion, this study failed to demonstrate that treatment with this dual CFTR modulator had any consistent impact either on glucose tolerance or insulin secretion. This was one of the very few studies which actually consisted of very large patient population as well as long treatment duration. The study was published in Journal of Cystic Fibrosis last year. They also investigated the effect of 1-year treatment of this dual CFTR modulator therapy on glucose tolerance in CF patients that had delta 508 deletion. The study consisted of untreated CF patients who either has glucose intolerance or were newly diagnosed diabetics. This was a prospective observational study, and abnormalities in glucose tolerance were evaluated using OGTT at baseline, and then they compared it with OGTT done 1 year after treatment. So at baseline, roughly about 78% of these study participants had impaired glucose tolerance, whereas 22% of the study population had cystic fibrosis related diabetes. So after 1 year treatment with the CFTR modulator, you can see that 50% of these study participants were able to achieve normal glucose tolerance. So this is a significant reduction from 78% down to 50%. And 40% of the subject had impaired glucose tolerance, whereas only 10% of the study population had CFRD compared to 22% at the beginning of the study. So again, it's a significant reduction, not only in impaired glucose tolerance, but also in CFRD. This table shows us some of the characteristics and the patient demographics, as well as some of the study metabolic panels. What we are seeing here is a significant improvement in the albumin. So we frequently use albumin to determine the nutritional and the metabolic status of these patients. There were no significant changes in the pre-treatment or the post-treatment fasting blood glucose. Neither was there a change in the 1-hour blood glucose during OGTT. But you can clearly see that there was a significant reduction in the 2-hour blood glucose during the OGTT, and the difference was statistically significant. So in conclusion, this long-term study showed an improvement in glucose tolerance following 1-year treatment with lumacaftor and ivacaftor. So most of the studies that I showed you so far, their main limitations were either very small patient number or very small treatment duration, or they consisted of patients that primarily had impaired glucose tolerance and had very small number of patients that actually had CFRD. So this got me looking into the effect of CFTR modulator, where my main focus was actually whether or not these affect the progression of CFRD. So for my study, the data was obtained from the Cleveland Clinic Cystic Fibrosis Registry. Patients that had CF as well as CFRD and were on CFTR modulators, either the single therapy or the dual therapy, were included in the study. We specifically excluded patients that either had impaired glucose tolerance or impaired fasting glucose. 24 patients met our study criteria, and I do want to mention that half of the study population were on insulin. The other half that were not treated with insulin actually had normal glucose values, and these patients frequently monitor their glucose fasting and then 2 hours after meals. We compared the changes in hemoglobin A1C, body weight, and FEV1 predicted pre and post treatment, and the changes were evaluated using the paired t-test. Statistical significance was set for p-value less than 0.05. This table here shows you the patient demographics. The mean age for these patients were 28.7 years, so much older compared to what I showed you in some of the previous studies. The mean duration for CFRD was 7.3 years, and the CFTR modulator duration was 27.2 months, so much longer than the previous studies that we shared this morning. This table shows the changes in outcome measures. Here you can see that the pre-treatment A1C was 6.4%, and post-treatment, again, we are seeing a significant reduction. FEV1 % predicted also significantly improved given the use of CFTR modulator therapy. And we also noticed a 2.2 kg weight gain during the use of CFTR modulator. This might seem very small to most of you that take care of patients with type 2 diabetes, but when it comes to cystic fibrosis patients, any weight gain is considered to be significant because it helps us improve their lung function. This figure shows the change in A1C, and as I previously mentioned, it did decrease significantly. And this bar graph shows you the improvement in FEV1 % predicted. This figure shows the change in weight, and as I mentioned, we did notice a 2.2 kg improvement during the duration of the study. Furthermore, we were also interested in determining whether there is a correlation between the treatment measure, between the treatment duration and the change outcomes. What we are seeing here is longer treatment duration was actually associated with a much greater reduction in A1C, as you can see here with the p-value. So in conclusion, what I showed in our study is that A1C significantly decreased after CFTR modulator therapy. Furthermore, we also found a positive correlation between the treatment duration of CFTR modulator and the change in A1C. However, insulin requirements did not decrease after initiation of CFTR modulators. To our knowledge, our study had the longest treatment duration with CFTR modulators and its effect on improving CFRD. There were few limitations of our study, the first one relatively being the small patient number. In addition, we did not have a control group, given the fact that CFTR modulators does lead to an improvement in CF lung function, regardless of whether they improve insulin secretion or glucose tolerance. Therefore, it would be unethical to have a control group. And then lastly, this was a retrospective study, so it was not possible for us to go back and assess whether there was an improvement in insulin secretion. However, if that would have happened, we would have seen a reduction in insulin doses for these patients. So Trikafta was the first triple therapy that was approved by FDA back in 2019 for the treatment of CF patients who had at least one delta 508 deletion mutation. Currently, there is an ongoing study. It's the PROMISE study, which is primarily assessing the effect of Trikafta on glycemic control. And right now, researchers in this field are more interested to determine whether early initiation of either Trikafta or one of the other CFTR modulators would actually lead to either prevention or delaying the development of CFRD. So I would like to thank my mentors, the Envision CF Grant, the CF Foundation, as well as my CF team at Cleveland Clinic, and I am happy to take any questions at this point.